Thank you, Partha, for once again having me in your course on ICL, which is always a houseful and well appreciated course. After that wonderful demonstration of how to implant an ICL, I am expected to deal with ICL in complex situations. I am a speaker for Star, and I have received financial support for travel from them, and they make the ICLs. Essentially, a good dilatation is usually given for these patients who have high myopia and fairly young in their age. But sometimes you come across a situation like this where the pupils are poorly dilating. In these cases, it's a bit of a challenge to inject these lenses. Don't choose them as your, do not choose them as your initial cases of implanting. But then it is always doable. Go through the side ports, have a nicely inflated anterior chamber, and then in a methodical manner you can gently tuck these haptics inside. It doesn't look very elegant, but it's essentially to show you that it's doable. But it's always a good idea to have a good dilatation, and at least in the initial cases you must aim for that. Having intracameral dilatation also helps. And in some cases, especially, it's very important that you do not overinflate. You inject too much of viscoelastic, as I've done in this case, then the rim of the pupil is not seen at all. I've had the consternation of seeing half the lens in the anterior chamber on the first post-operative day, because it's essentially because it was not tucked in properly. So all you have to do in this situation is to just let a little bit of viscoelastic out so that the pupillary margin comes into relief, and then you can just do what you have to all the time, gently tucking the haptics behind the pupillary margin. And it's always a good idea to do it through the side ports. That gives you better control, more stability of the anterior chamber. It's extremely important that you always inject these lenses the right way up, because it's not only a question of getting an inappropriate refractive outcome. Because of the vault of these lenses, if they are injected in the wrong way, the optic of the lens will sit on the anterior capsule. So here you can see that even after 7/8 of the lens is injected, I am having control over the lens. Just by twisting my wrist around, I am able to orient this lens in the right way. This side port is always there to help me, just in case it becomes necessary, though you are not supposed to touch the central optic, which is just about 50 microns in thickness. If it's necessary, I can always use that to help the lens open up the right way. This is just lens being injected in the anterior chamber, and then subsequently the tucking will take place. Let us look at another situation where it's gone a little more out of control. This is why I use the spatulated instrument that I have readily there. It not only stabilizes the eyeball, but it also comes of use. Here what I do is to gently tuck on the central optic, though it's not routinely recommended, but I would rather have the lens opening up the right way. In case it has opened up completely in the reverse direction, it's not a good idea to try to reverse it in the anterior chamber, but bring it out of the anterior chamber, reload the lens, and then go ahead and inject these lenses. Almost 80% of the lenses, the ICLs that I use, are toric implants, essentially because very often the myopia does come with a certain amount of astigmatism, and when you're using a technology like this, it's not a good idea to leave behind astigmatism uncorrected. This is a kind of, you can see, somewhat compromised corneal situation. So we are going ahead and implanting a toric ICLs. I usually do on alternate days, do one day, see the patient the next day, and do it the day after. And this is the toric ICL rotational chart that I got, which shows that it has to be 6 degrees in the anti-clockwise direction. Essentially, the visual outcome was plano in the right eye, and this was the outcome in the left eye. Even if you get a simple cylinder, just readjusting the position of these lenses does help, but it's especially in a situation like this, when the spherical equivalent of the residual refractive error is almost zero. That is 0.87 is the cylindrical error, and this here you have a plus 0.75. It definitely tells me that repositioning this lens is definitely going to help. In case of doubt, you can also get back to the company and with the preoperative and the intraoperative data, and they will tell you how exactly to orient these lenses. So essentially, what I do in this is just injecting viscoelastic, and removal of that itself causes malpositioning these lenses sometimes. So I did realize that this was 1 degree in the clockwise direction. So all I do is just go ahead, and you can see that I go 7 degrees, orient this ring in the where the haptic markings are. That may not be obvious to you, but take a mark about 7 to 8 degrees away in the anti-clockwise direction. I do not use any viscoelastic. I did this almost after the 1 month after the primary surgery. But now if I had to face this situation, I would go along and do it even a week later, because I do believe that it's extremely important. It's possible to get very appropriate visual outcome, refractive outcomes in these situations. All I'm having is a irrigation cannula inside the anterior chamber. I'm gently rotating this lens into position, which was marked with just a small blood spot occurring because of a 26 gauge needle. There's no preoperative marking necessary in this situation, simply because all you have to do is to orient the lens 7 degrees away from its present position, and that's something achievable, and even on the first or post-operative day, you would almost get a optimal outcome. Yeah, we have done quite a bit of toric ICLs for keratoconus patients once it has stabilized. I'll be talking about that. And in these situations, sometimes you get an inappropriate outcome. And if it's a large surprise, it's better to exchange these lenses, and that's exactly what I'm doing. All you need to do is to bring out the haptic of the lens into the anterior chamber. Please do remember you have a clear lens behind, so obviously these maneuvers have to be controlled and gentle so as to not to damage the anterior capsule. Go ahead with the same front-holding forceps that you, front-loading forceps that you use for pulling the lens into the cartridge, with a hand-over-hand maneuver without any enlargement of the incision through the same 3 millimeter incision. Because the collamer material and the extreme flexibility of this lens, you can bring this lens outside and inject the lens at the right power inside. Usually it's an extremely satisfying experience as far as the patient is concerned. Of course, you do not like the idea of going through a second surgery. Post-penetrating keratoplasty, you know, various forms of keratoplasty that are being done here, in spite of an excellently clear cornea, sometimes because of the residual astigmatism, you have an inappropriate refractive outcome. In these situations, a toric ICL implantation is extremely helpful. Here you have to be cognizant of the fact that it's a donor cornea that's there. Be more aware of the endothelial cell counts. So essentially make a limbal or a near-scleral incision, and your maneuvering has to be much more gentler. These are situations where you essentially debulk the refractive error and debulk the astigmatism. It's not absolute emmetropia that you're aiming at, but once implanted, many of these patients seem to do quite well. Anterior subcapsular cataract is a matter of concern because the proximity of the optics of the lens to the anterior capsule. The incidence is about 1.3% in the FDA study. So you get, these are my own cases, these are limited anterior subcapsular opacity. This could occur because of surgical trauma or because of minimal vaulting. If it's not progressive, you don't have to do anything about it. But here is a case of classical anterior subcapsular cataract which occurred because of the ICL itself. It is a nuclear sclerosis that occurred in a high myope that may not be attributable to the lens per se, but here obviously it's an anterior subcapsular fibrosis and it's because of the lens. Sometimes in spite of the appropriate vaulting, because of disturbances in the aqueous inflow, you come across these situations. But I must say that I've just done about 2 of these explantation and remove intraocular lens implantation. And it's not that none of the other eyes did develop a cataract, but usually it's a very small specks of opacity which doesn't seem to bother the patient visually. So again, the principles that I told you enunciated earlier, that is the lens comes out through the same 2.8 millimeter or 3 millimeter incision. Go ahead and do your phacoemulsification and implant the intraocular lens power of your choice. There's no change in the power calculation per se, because laser light or the ultrasound passes just through 50 microns of this material, which doesn't impact upon the axial length calculations. We have implanted on KC cases, not in the once because of the aging of the patient, say 40, 45, and we have sequentially found that the KC is quite stable, or we have done a collagen cross-linkage subsequent to a period of about a year, especially when an extremely well-centered cone like this, and the patient is improving very well to 6/9 visual acuity, I go ahead and implant ICL. The procedure is no different, so I'm not going to show a video. A more extreme case where the patient actually underwent LASIK elsewhere. My cases have also developed iatrogenic keratoconus, but this patient happened to be done elsewhere. He developed iatrogenic keratoconus, did collagen cross-linkage, and subsequently implanted a toric Intax rings, and all done at a period of about 1 year difference. And then in these cases, because there was a significant astigmatism that was left behind, I'm going to go ahead and implant a toric intraocular lens for the residual error. So basically, iatrogenic keratoconus, collagen cross-linkage, implantation of the intacts to center the rings, and then subsequently a toric ICL implantation. This just gives you an idea of the options available to a modern day refractive surgeon, and in case you optimally use them for the right kind of indications, very often you are able to address fairly difficult situations like this. And though the patient was extremely unhappy with the initial outcome to refractive surgery, today she is quite a happy patient with a 6/9 uncorrected visual acuity. Otherwise, the implantation of the lens is no different. I just wanted to show you the concept that's employed. My initial experience, both Partha and me went to Germany to get trained in this implantation of iris clip lenses together sometime back in 2002. And initially all my experience was limited to these lenses. It was a gradual drop in the endothelial cell count that essentially took me away from these lenses. This is a patient who had excellent visual outcome, and she had a 6 uncorrected visual acuity, but her endothelial cell count had dropped down to 1,500. Given a choice, I would have just liked to remove the lens and leave the patient behind with glasses or contact lenses. She insisted on not giving up the refractive outcome that she enjoyed. So what we are essentially doing, in spite of the fact that the cornea looks quite clear on the under the operating microscope, it's one with a compromised endothelial cell count. It's a 6 millimeter incision that I have created to essentially explant these lenses, and subsequently implanting a ICL, in this case a toric ICL was not required. We have been sequentially following up these patients for the last 5 years, and there has been no further endothelial cell count loss. I think it's essentially because the distance of these lenses from the ICLs, from the endothelium of the cornea, that these lenses do reasonably well. I think the last of my videos, that's just a... this is what I call what's called a brittle cornea syndrome. You can see it's not just bad surgery. There's something wrong with the cornea also. And this is one of the very few occasions when I actually had to suture up the cornea. And as you can see, as I proceed with this surgery, the cornea seems to just give way. Almost it's opening up. It was just a 2.8 millimeter incision. I do not believe I'm doing anything wrong, but you can see all the viscoelastic escaping, and the anterior chamber was virtually flat. And as we will proceed, we'll see that even the side ports give way. And this was exactly the experience that I had even with the other eye, which I did a week later on the patient's insistence. I could not actually position these lenses because the chamber was constantly flattening. So I had to put in the sutures in place. And as you can see, it's not a very elegant surgery, but sometimes you come across situations like this and you need to handle them optimally. Obviously, the pupil had come down because of the unstable anterior chamber. And that's the lens in place. And as you can see, as I evacuate the viscoelastic, even the side ports seem to give way. There is constant leakage of fluid over here, and I have to suture up these incisions also. And this is what I think I'll just go to the end. And that's what you saw. I had to actually remove the speculum to reform the anterior chamber with an air bubble. But this was the picture a week later, and you can see a fairly ideal vault. And actually the patient insisted on going through the second eye, which I did a week later, and with exactly the same kind of picture. But fortunately, it worked out reasonably well for the patient. I think I'll skip this, just using a toric ICL with a Varion guidance. And this is just to show you that you can have this online marking tools essentially to position the lenses, and this has subsequently enhanced the outcomes. Thank you so much for your kind attention.